and I have the distinct pleasure of inviting Dr. Sigman, who's going to talk about the foundational clinical indication of TCD in critical care, which is transcranial Doppler use in delayed cerebral ischemia. Erika?
Yes, I am just sharing my screen 1 second. All right. Can you see my screen now?
Yes.
Awesome. Great. Well, thanks so much for having me today. Oops, I'm so sorry. Can you still see my screen?
Yes.
Great. All right, great. So I'll be talking about transcranial Doppler and subarachnoid hemorrhage, as already said, and these are my disclosures. So you have a subarachnoid hemorrhage patient. Here's their scan that looks like a pretty diffuse subarachnoid hemorrhage. And so—
Erika, your slides are not advancing?
Not advancing? Okay. 1 second here.
You might want to use the share button and actually do it on the PowerPoint rather than the screen. You may have two screens, looks like.
Yeah. 1 second. Oops. Oh, goodness. Let me just start over and stop share and try to reshare. That'll probably work. All right. Did that work now? Let's see. Is it advancing?
Perfect, thank you.
Okay, sorry about that. So these are my disclosures. This was the CT I was talking about. So you have diffuse subarachnoid hemorrhage here from an aneurysm. And so this is showing you what's going to happen over the coming days. I think it's a nice picture of the natural history of subarachnoid hemorrhage, where you have the initial rupture of the blood in the CSF and reduced cerebral blood flow levels, which leads to a cascade of events, including, these inflammatory cascades, necrotic pathways, which ultimately lead to cerebral vasospasm, microvascular spasm, loss of autoregulation, and inverse hemodynamic response. The thing that we're interested in when thinking about TCDs is trying to detect cerebral vasospasm and see how we can use it to predict DCI, or delayed cerebral ischemia. So just a couple of definitions that we'll go through in subarachnoid hemorrhage. So you've got cerebral vasospasm, which is narrowing of the cerebral arteries that are detected on the various imaging modalities. Here is a CTA shown where you have left MCA. You can see this spasm and narrowing of the vessels over here. This typically, in historical literature said to, occur over the first 3 to 14 days, but now we know that it can be 21 days and beyond after subarachnoid hemorrhage, and it may be asymptomatic. And then, the really feared complication of subarachnoid hemorrhage is delayed cerebral ischemia, where you have a new focal neurologic deficit not caused by anything else that you're working up, not like new fever, seizures, hydrocephalus, or the radiographic diagnosis, which is a new infarct on imaging, whether that's CT or MRI, and it occurs in the same time frame as spasm. And so the relationship between vasospasm and DCI is kind of interesting. So we see evidence of spasm in up to 70% on angiography, or cerebral angiograms, or CTA, but only 20% of these patients, 20 to 30% of the patients develop DCI. And some patients with severe spasm don't develop DCI, and some patients with only mild spasm end up developing DCI. And DCI can even develop in a vascular territory separate from where you saw spasm. And so, as you saw in the previous talk, the reason why we can detect spasm or narrowing of the vessels in TCD is because of the Spencer-Reid curve, where you have, up at the top, you have a decrease in your cross-sectional area of the vessel. And as that happens, you have some stable blood flow up to a point, but the velocities increase as your cross-sectional area of the vessel decreases. And so using TCD, we can detect this. So here's an example of it on the right. So we're intubating the right and left MCA of this patient. And you can see borderline elevated mean flow velocities in the right MCA and really, really high mean flow velocities in the left MCA. And so how well does TCD work to predict spasm in the anterior circulation? So that's what we have the most information for, most evidence for, less evidence for the posterior circulation. And so this was a meta-analysis of 7 trials, both prospective and retrospective, that was comparing MCA vasospasm and ACA vasospasm in patients with subarachnoid hemorrhage from an aneurysm. And they used a TCD mean flow velocity of greater than 120 to greater than 140. So there was a range of mean flow velocities used in the study. And they found that across this meta-analysis and all the studies that they looked at, the MCA had a specificity of 99%. The TCD had a specificity of 99% for detecting vasospasm in the MCA and a positive predictive value of 97%, but not very sensitive. Here you can see 67%. And so, this suggests that if TCD indicates spasm in the MCA, you're likely to have spasm on your cerebroangiogram. In patients where the TCD doesn't indicate spasm above that mean flow velocity range of 120, you can't be sure if there's vasospasm. But remember that these trials looked at a wide range, 120 all the way up to 140 centimeters per second. And then the ACA was not very highly sensitive or specific. And that's probably, partly due to the challenges of insonating the ACA and the angle. This was a more recent meta-analysis that looked at 15 studies. They defined mean flow velocity elevation or vasospasm as 90s to 150, so a broader range than the prior meta-analysis. And it again showed the trend that TCD is likely to detect spasm in the MCA, but would not be able to exclude or rule it out. And then it turns out if you break down the TCD velocities in the MCA, that's probably helpful in terms of ruling out spasm or ruling in spasm. And so this was a study that looked at TCD compared to cerebroangiogram, and they had more, defined cutoffs for what different mean flow velocities meant. And so a TCD mean flow velocity of less than 120, this, had a sensitivity of 88%, negative predictive value of 94%. So, felt that this is very, if patients' velocities are less than 120, very unlikely to have vasospasm in the MCA. And then if the TCD's velocities are greater than 200, this is strong evidence that you have vasospasm with a very high positive predictive value, likelihood ratio of 16. So probably something you want to act on. Now, these intermediate values here are less reliable, as you can see. And so, operationally, it gets really challenging when you're doing TCDs on your patients with subarachnoid hemorrhage, and you have these intermediate velocities. I generally will obviously compare to the exam, get additional imaging, CTA, CTP, and just get additional imaging. And, sometimes, take that patient down to cerebroangiogram. For posterior spasm, there's smaller and fewer studies, and so we really need more data. It's poor performance to detect spasm in the PCA. There's some small studies that compare or that look at vertebral artery and basilar artery spasm, and they're conflicting, and you see a wide range of specificities and sensitivities, but it seems to have decent specificity for detection of spasm, especially in the basilar artery. And then, what is probably more interesting is, using TCD as a biomarker of who's going to develop delayed cerebral ischemia, the feared complication of subarachnoid hemorrhage that increases your morbidity. How do we know? And TCDs seem to be almost like a crystal ball and who's going to detect this and maybe who's not. So This was a systematic review and meta-analysis of all studies through 2014, and they looked at the predictive value of TCDs to detect DCI in aneurysmal subarachnoid patients. It was a combination of prospective and retrospective 17 different studies. And TCD vasospasm was defined again as greater than 120 centimeters per second. And they didn't have to require cerebroangiogram confirmation of vasospasm in these studies, which was interesting. But the pooled estimates for TCD diagnosis of DCI or prediction of DCI are shown here, but seem to be 90% sensitive and a 92% negative predictive value. And so it seems that cerebral vasospasm seen on TCDs may predict DCI with high sensitivity and high negative predictive value. And so it seems to be a really nice screening tool with low false negatives. This was just a retrospective single cohort study that looked at over 262 patients, again with aneurysmal subarachnoid hemorrhage, and looked at their outcome was radiographic DCI. So not clinical, but radiographic. Here was how they, graded the severity of TCD mean flow velocities. And just to point out, the Lindegaard ratios in all of these gradings had to be greater than 3. Lindegaard ratio is the ratio of the mean flow velocities of the MCA over the ipsilateral ICA. And so TCD measured vasospasm severity was associated with radiologic DCI. And then an early TCD-based vasospasm seemed to have a high negative predictive value. So seems to be that, if your TCD's mean flow velocities are totally normal, that person is probably not going to develop DCI. It doesn't mean you might not continue to monitor for a few days by TCD, but, pretty reassuring when seen serially. And so for vasospasm, just to kind of sum this up, so TCD is most accurate for detecting MCA vasospasm. Low velocities in the MCA may help rule out presence of spasm. I say that with an asterisk because it's we don't have clinical trials or multi-center things right now, and the data is not the best quality. And then false positives can occur. People can have high velocities for other reasons, right? Fever, anemia, hyperemia, that's not spasm. And that's why we use Lindegaard ratios to try to increase our detection of the spasm. And then false negatives are possible. This is one of my favorite things we don't have time to talk about right now, but we're only insonating very proximally in the proximal vessels of the circle of Willis. And so you think about what's happening distally for spasm, we're not able to detect that on TCD. Now, sometimes if you have very distal spasm, you can see a change in your waveforms or, a high resistance kind of spiky pattern that can let you know there may be increased distal resistance, but there's other things that can cause that. So you have to interpret with caution. For DCI, it's TCD vasospasm has a high sensitivity and negative predictive value for development of DCI. And so the way we're using this in our center is serially to rule out development of DCI. And so TCD in the SAH guidelines, many years ago, there were some AAN guidelines that have been retired, but most recently, commented on in the neurocritical care guideline management of aneurysmal subarachnoid hemorrhage, and then also the AHA 2023 guidelines. The AHA guidelines, there's a class 2 recommendation for TCD monitoring for detecting vasospasm and predicting DCI. It's not higher than this because we're lacking high quality studies that demonstrate, patient-centered outcomes. And then the NCS guidelines, even kind of a more disappointing recommendation that basically there's insufficient evidence to provide a recommendation. But, it's not closing the door completely. It's saying we need more information about how this could possibly change patient outcomes. Research gaps, I think the primary one is, multi-center trials comparing TCD driven versus non-TCD driven management. So how are patient outcomes in patients that, you manage their medical care with, using TCD guidance versus non-TCD guidance. And of course, there's others, but I think those are some big ones. Education gaps, most neurology residencies aren't, including TCDs as a formal part of their training. At our center, the stroke fellows and the neurology residents can take, TCD reading as an elective with us, but it's very short. It's 1 week. It's not enough. There are courses out there. I have in our team science education paper, we listed a bunch of different courses and resources out there. That's in this QR code. I mean, you guys will get these slides or have access to these slides. And then competency requirements, of course, getting your RP&I to interpret TCDs, but of course, this isn't specific for vasospasm. And then clinical gaps. We know about as I mentioned, there's the RP&I credentialing for reading TCDs. Now, you can certainly read them without your RP&I, but it is recommended if you are in an accredited lab. Again, this is not necessarily focused on spasm, but I think it's relevant. And then, of course, we talked about the society guidelines or lacking consensus statements. And so development of DCI is complex, and we know that vasospasm is associated with DCI. Transcranial Doppler may be useful screening for development of DCI and a nice confirmatory tool for MCA spasm specifically. I can't say enough about how convenient it is to us as practitioners, right? Like there's no transporting the patient, no radiation, no contrast, non-invasive, and you don't have all of the potential downsides of, vessel injuries and stuff compared to cerebral angiogram. But TCD evidence of vasospasm on patient-centered clinical outcomes following subarachnoid hemorrhage is unknown, and that's a big caveat. I have a little TCD interpretation and vasospasm grading that I provide the fellows and the residents that you can have here. And that's it. So you can put your questions in the Q&A, and then they'll answer them around 10 o'clock. Thank you so much.